We're going to talk about abnormal heart rhythms. Last video, we talked about different parts of EKG, how they relate to the heart and the cardiac conduction cycle, and what a normal EKG should look like. Now that you know what normal looks like, it should be easier to identify abnormal rhythms. If you're doing an EKG on somebody, or in general have somebody on continuous cardiac telemetry, there are basic rhythms you should look for and know immediately that something is not right. And just a quick review, this is what an EKG of normal sinus rhythm should look like. One thing to note right away, sinus bradycardia and sinus tachycardia are measurements within normal limits, but your rate is either less than 60 or over 100. The first two rhythms we'll talk about are very easily identified. These rhythms are ventricular fibrillation or ventricular tachycardia, otherwise known as VFib or VTach. They're usually not compatible with life because they're not usually perfusing rhythms. I will say I've seen people in VTach who are a little uncomfortable, but otherwise straight chilling. So make sure you always look at your patient before you do anything crazy. In ventricular fibrillation, the ventricles of the heart are essentially just quivering. They're not fully contracting and they're not moving blood forward, so you are not oxygenating. Very easily characterized by this little squiggle in every single lead. When you look at this, you can see that this whole rhythm is not very tall, which reflects the just slight contraction or quivering action that the ventricles are performing. Sometimes up here, you maybe could possibly say torsades de poids, but I'll show you what that EKG looks like and you'll see the difference. The best thing you can do for somebody in VFib is shock them, and the sooner you shock them, the better their potential outcome will be. The next rhythm is ventricular tachycardia. It's important to know that there are multiple kinds of ventricular tachycardia: polymorphic VTach and monomorphic VTach. Monomorphic being everything looks the same. Polymorphic means that it doesn't look the same. Ventricular tachycardia has a wide, complex QRS, and it's essentially this uncontrolled firing and contraction of your ventricles. When your ventricles are contracting this fast, rates 200 to 300, you can't fill them. And if you don't have full ventricles, you can't move blood forward. So if you see these tombstones and you look at them and they don't look that great, the best thing, again, you can do for them is shock them. Here you have polymorphic ventricular tachycardia, and more specifically, torsades de poids. If you look at this, you can see how they're not very uniform. You still have the wide QRS complex, but it's just kind of all over the place. Now, not all polymorphic VT is torsades de poids. To meet the definition of torsades de poids, you need to have a long QT prior to your polymorphic VT. And this is why we talked about why the QT interval is so important. When you have a long QT, you have positive and negative impulses that can sort of clash in the conduction system and then throw you into a non-perfusing rhythm. Again, the best thing you can do for this patient is shock them and give them magnesium. On an off note, there are only two abnormal cardiac rhythms that you can shock, and it's VFib and VTach. If you're considering shocking any other rhythm, you need to make sure it's a synchronized cardioversion. And this is because you have to hit the heart at the right time in the cardiac cycle, otherwise you'll throw them into a crazy abnormal rhythm. Another thing that isn't necessarily applicable to everybody, but everybody should probably be aware of, is what a PEA arrest is, or pulseless electrical activity. Somebody who's experiencing a PEA arrest will have a normal rhythm on an EKG. They just won't have a pulse. This is why it's so important to always look at your patients. Two very common atrial dysrhythmias that we see are atrial fibrillation and atrial flutter. Atrial fibrillation is essentially the quivering of the atria. A lot of these impulses are blocked by the AV node, but because of the initial irregularity, you still get irregular rates. And because of this, you'll see irregular spacing between all of these QRS complexes. You'll also see that you can't see a PR, or if you do, you don't see them very consistently. People who are in AFib usually need to be anticoagulated because that forward flow of blood is impaired and that it can sit and pool in those atria, creating clots. Clots are the last thing you want flowing through your circulatory system, especially getting into your arterial system. The other thing that you want to make sure with AFib is that they're rate controlled. Every once in a while, you'll see AFib with RVR, which means rapid ventricular response. It basically means that there's no stopper on these impulses that get sent to the ventricles, and you get really, really, really fast heart rates. We usually treat these with beta blockers. You also can use antiarrhythmics like amiodarone or diltiazem. Sometimes we even cardiovert these patients or even start them on medications like Ticacin or dofetilide, but those have high risks of long QTC, and we know long QTC can cause torsades de poids, which is not good. Atrial flutter is just a constant, fast, full contraction of your atria. Now, just like in AFib, in a flutter, not every single one of these atrial impulses are getting sent to the ventricles because they are being blocked by the AV node. When we refer to a flutter, a lot of times we say 2-to-1 A flutter, so 2 atrial contractions for every 1 ventricular contraction, or 3-to-1, and so forth. The main thing you look at in these rhythms is how fast the heart is going. Now, neither of these rhythms are necessarily an emergency unless the rate is so fast that it's causing circulatory compromise. Another easily identifiable dysrhythmia is supraventricular tachycardia. SVT initiates in the atria of the heart, similar to atrial flutter, except there's no blocking by the AV node. In SVT, you usually have rates over 150, sometimes well over 200. In SVT, your P waves are usually obscured in your previous conduction cycle because your heart is just beating so fast. When people are in SVT, it's usually not very comfortable. They feel like their heart's racing or they have palpitations. Sometimes it can cause circulatory compromise, and if the heart is going fast enough that it does, then this could potentially be an emergency situation. But if your patient is stable, people can sit in these fast rhythms like this and AFib with RVR for a while. The last thing I'll talk about in this video are heart blocks and junctional rhythm. If a part of the conduction cycle isn't working, your heart has some built-in backup fail-safes. For example, if your SA node isn't firing, your AV backup rate is usually 40 to 60. If that's not firing, then the ventricles will probably fire at about 20 beats per minute on their own. Junctional rhythm occurs when the impulse is not coming from the SA node, but the impulse is coming from the AV node. And when you think about heart anatomy, your SA node is above your AV node. If your AV node is the part that's firing, it has to go back up to the SA node in the right atrium and then over to the left atrium. So it's essentially conducting backwards from normal. Because of this, you'll notice in a junctional rhythm, you have an inverted P wave or no P wave at all. The names of different junctional rhythms are essentially based on how fast they are going. The AV node backup rate is about 40 to 60, so that's just junctional. Accelerated junctional is 60 to 100, and junctional tachycardia is a rate over 100. When we talk about heart blocks, there are 3 different specific types of heart blocks. This is where knowing normal intervals of the conduction cycle come in handy. In a first-degree AV block, it takes longer than normal from the beginning of atrial depolarization to the beginning of ventricular depolarization. Somewhere along the road, things aren't going the way they should, and it just takes longer than normal. Building off of this, you have a second-degree type 1, or a Mobitz 1 or Winkelbach. In this rhythm, your PR interval gets longer and longer and longer until you drop an entire QRS. You can remember this by longer, longer, longer drop. Now you have a Winkelbach. If there's no change in your PR interval along your rhythm and you just randomly drop a QRS, that's called a Mobitz 2. If the impulse can't get through, now you have a Mobitz 2. And finally, the most dangerous, a third-degree heart block. You can identify a third-degree heart block because 1, the rate is usually slow. And 2, All of your QRS complexes are equidistant and all of your P waves are equidistant. But in a third degree heart block, there is no correlation between your P wave and your QRS. There is no communication between the top of your heart and the bottom of your heart, which impacts perfusion. When you're in a third degree heart block, your QRS rate is usually that ventricular backup rate, so it's quite slow, like 20 to 40 beats. The last block I'll talk about is a bundle branch block. This happens when there's damage to either the right or left bundle branch. It's that pathway that's sort of in that middle wall of the heart and the ventricles. When this happens, there's sort of an interference in how that electrical impulse comes down and goes into the Purkinje fibers. Essentially, it has to re-find a new pathway and just takes longer to complete that full contraction, and this is how it's reflected. This can cause the ventricles not to contract completely equally. They both will contract, just one might take a little bit longer than the other. The interesting thing about this is sometimes you can physically hear this when you listen to somebody's heart. Not because you can hear the contractions, but you can hear the valves opening and closing. Anyways, I hope you enjoy this, and maybe I might do another video on pacing and STEMI and STEMI.